Now I would request Dr. Omar to please raise the dais. Dr. Goel sir, Dr. Muhammad Shahid sir, to please raise the dais.
Dr. Omar, to kindly introduce the speaker.
A very good afternoon, everyone. I would like to invite Dr. P.K. Goel, who is currently the Director Interventional Cardiology at Vedanta, Lucknow, ex-professor and head Department of Cardiology, Sanjay Gandhi Postgraduate Institute. He was there for the last 11 years before he joined Vedanta, and he joined SGPGI way back in 1989. MBBS from Maulana Azad, MD from Maulana Azad, his DM from GB Pan, and fellow of American College of Cardiology, CAI. And let me tell you, he's one of the pioneers to start the Indo-Japanese CTO club in India, which is called as IJCTO. It's a very prestigious conference held in July every year. And his fellowship training was from New Zealand in Auckland in coronary intervention and cardiac radiology. Special interest, like I told you, is cardiac imaging and CTO. And so many papers and so many projects, including the latest TAVI MyValve person-man trials and the stem cells therapeutic trials. So over to you, sir.
Thank you for the introduction. So I am going to talk on the interventional cardiology today, what every physician should know. Now this is, I made it more general, what I would like to, it's not, how does it change the slides? Okay. All right. So, you see, I'm going to talk on intervention, but cardiovascular disease is the world's biggest killer, and it's about 56 million total deaths, of which 36 are 31 is cardiovascular disease, half being stroke and half being coronary heart disease. So, if this has to reduce, I think more than intervention, prevention is more important. So I would say that at the outset. So one has to certainly do prevention, but yes, there are points and times intervention is required, and that's what we're going to talk about. So now the new therapeutic arenas in cardiology include newer lipid guidelines to lower LDL targets in post-PCI patients and high-risk cases with the use of PCSK9 inhibitors, the CUMABs, the evolocumab, oligocumab. So this is one trend that's coming. Bempedoic acid in patients who are statin resistant. Newer heart failure management protocols like ARNI, SGLT2 receptor blockers, the gliflozins. Rapid sequencing algorithm of initiating therapy, that you should start all 4 drugs or 5 drugs almost simultaneously in small doses. The GUATs, that is the Vericiguat and Ricoguat in worsening heart failure. Now these are very strong trends which go hand in hand with interventional cardiology, because this, if you don't do this, then just doing intervention is not going to work. NOACs in the stroke prevention of atrial fibrillation. Scope of coronary intervention today and the decreasing need of open heart surgery. When I make this statement, I say as future goes on, what is happening is that the surgeons are getting more and more mini, and the cardiologists are getting more and more maxi. Mini and maxi, the surgeon wants to make smaller holes, cardiologists are making bigger holes. I am sure down the line, 20, 30, 40 years, I am sure there will be only one way to treat the disease, and that will be whether the surgeon does it or cardiologist, and that's what I'm going to show you. So primary PCI in a setting of acute MI with an intent to open the culprit artery is standard of care and needs to be done, and the remaining vessels can be done stage 2 in the same admission. Then you have elective PCI, which could be a single vessel PCI, no problem. Multi-vessel PCI with type A and B lesions and acute subtotal occlusions. That is also okay, is being done, can be done. Now comes the complex coronary interventions. Now what is complex? CTO intervention, left main bifurcation PCI, multi-vessel PCI with complex disease, long segments, bifurcations, calcium, calcific disease calling for rota, IVL, imaging guided PCI. You can do imaging looking inside the artery. PCI with mechanical support like Impella. Now the days of high restenotic rates are gone. Well-performed procedures give recurrence rates of less than 5%. Please understand and mark your, if it's well done, the recurrence rates will not be more than 5%. What you need is good interpretive and a well-performed angiogram. The angiogram has to be interpreted well and performed well, then you can make right decisions. Operator skill certainly is supreme in these high interventional procedures. But does it mean surgery is gone? No. When do I advise surgery? Multiple lesions in each vessel with rather diffuse nature of disease. I think surgery is a better option. Multiple complexities all together in the same patient. The same patient has left main disease, there is calcium also, there is long segment disease also, there is a bifurcation also, and there is left main with triple vessel disease. Well, then surgery is needed. If, although individually you could handle calcium independently, you could handle CTO independently, you could do left main independently. If having done PCI, you are still left with important vessels which will not be revascularized and are part of the ischemic triad, which are part of ischemia producing vessels, then again probably you should have surgery. But if LAD is not to be intervened, then I would say usually do not ask for surgery. Surgery is best for LAD, so that is important. Then comes the structural heart interventions. In overview, we can do transcatheter aortic valve implant. I'm going to talk to you a little about it. Endovascular repair of aortic aneurysms, device closure of holes in the heart like ASD, BSD, RSOVs, left atrial closure to prevent stroke in patients who are of high bleeding risk, transcatheter mitral valve repair in patients with mitral regurgitation who are otherwise high risk for surgery, and renal denervation therapy, which was mentioned by the previous speaker, in uncontrolled or resistant hypertension. Now, transcatheter aortic valve implant, I wanted to bring this up because this is a topic which needs a little awareness on the part of physicians. Now, this is done largely for degenerative aortic stenosis, which occurs with increasing age, can be diagnosed on auscultation of a murmur and an echo gradient across the aortic valve, which is diagnostic. Long latent period for symptoms, but once symptomatic, it has a rapid downhill course. Asymptomatic severe AS, which is peak gradient more than 4 meters per second on echo, also needs to be operated. And the only treatment is valve replacement, surgical, open chest, or otherwise. Otherwise is the transcatheter things, and that's what, you see the valves, basically leaflets get thickened because of deposition of cholesterol and calcium with age, and the opening reduces, and that's aortic stenosis. Now, what are the symptoms? How can you pick it up? Patient will complain of shortness of breath, dizziness or fainting on exertion because cardiac output is fixed, chest pain on exertion because these people will get angina, and feeling tired or fatigued, and swelling in your legs, which is almost the pre-terminal stage when you start heart failure on aortic stenosis. Now, this is a graph which shows that there is a latent period, but once the symptoms start, there is a rapid downhill course. So survival after onset of symptoms is only 50% at 2 years and only 20% at 5 years. Mark this word. So it has to be really intervened. You can't, because several, these are old people, have aortic stenosis, and then they say, oh, it's okay, I'm old and not, but if you intervene on aortic stenosis, it gives you a real grace of life, I can tell you, good quality life. Surgical intervention for severe aortic stenosis should be performed promptly once even minor symptoms occur. Now, this is some trials which compared surgical procedure versus transcatheter. So it was initially in extreme surgical risk patients which were inoperable, so TAVI was better than medical therapy certainly. And then there were the high surgical risk patients. These are randomized large trials which have made the guidelines. TAVI was better 1 year survival than surgical AVR in patients who were high surgical risk. Patients with intermediate risk, TAVR had similar outcomes to surgical AVR. That is, it is non-inferior to surgical AVR. And then patients in low risk, we have more trials. So the death stroke rehospitalization was lower with TAVR, that is catheter procedure versus surgical aortic valve replacement, with absolute risk reduction of 6.1% and the relative risk reduction of nearly 50%, trying to say that even in low-risk patients, transcatheter procedure is much better than and that's how it's approved in the FDA. So what is the paradigm today? Like in 2009, it used to be that if the patient is high risk, inoperable, then you do transcatheter procedure. But today, if the patient is high risk for transcatheter procedure, say he has a very tortuous iliac artery through which we cannot go, and there's a very heavy calcium excess is problem, there is a lot of calcium in the LVOT, there's a problem. So if it's not good for TAVR, then only surgery. Otherwise, majority have to go by transcatheter. That's the balloon expandable valve, one of them, and this is, I'm sorry, that was the self-expanding valve, and this is the balloon expandable valve. I'll just show you a couple. So the barriers in therapy, why it is not catching up as strongly. One is awareness. People are not aware that TAVR is a procedure for aortic stenosis. Second is some patients' affordability. This is an expensive procedure. Well, why? That's a different matter. We are not here, well, we cannot discuss that, but it's pretty expensive. And patients' identification and a lack of a good referral path, because it is the physicians who have to identify aortic stenosis within their patients and then get the patient to the right doctor. So those channels are not as available. Well, my TAVI experience, I did the first TAVI in 2016, and that was the first in a government setup of the country. Was part of the Merrill trial, and whatever, and then now it was approved. And today, I'm one of the operators, independent operators for TAVI, at least in the state of UP, that's it. So this is just certificates there. Now, trying to see the TAVI case examples. Now this is for a patient with severe aortic stenosis, annulus sizes there. Well, I will not go into the details because these are technical points. So you can see this is a CT picture with the calcified aortic valve. The two leaflets are fused and non-coronary is free. So this is these are some tortuosities in the iliacs that can be there, but it's calcium free, so you can do it. Planned for a self-expanding Medtronic valve with a 28 millimeter annulus. This is a chart which shows then you choose a 34 millimeter valve. Usually the valve size is oversized here because it's self-expanding. So if you see here, that's aortic stenosis. You see the limited mobility of the aortic valve. That is the angiogram of the aorta. And you see some leaking contrast, that is AR is also there. And then you cross the valve with a wire. So, and once crossed, so that's the wire that's going in, and then exchange to an extra support wire, which is a stiffer wire on which the valve will go in, which is, and then do some pre-dilatation, that's a balloon. You pace the heart at a high rate so that the balloon will not move, otherwise with the force of the pumping chamber, the balloon keeps pumping up and down. So by pacing it at a very fast rate, you reduce the blood pressure transiently and then you inflate it. And then that's the valve that comes in. These valves are about 14 to 18 French size, which is 5 to 6 millimeter holes which are made in the groin. And then it is going to start, and that's deployment. So I'll not. So gradually you will see this expand here as it is, as the sheet is being withdrawn. You see it is getting expanded, and it will align itself and touch the annulus. And at that time, transiently, there will be a BP fall, but then you release it faster, and then the valve starts functioning. And at this stage, you see the valve has started functioning, and then once you are confident that the positioning is okay, and then you release the valve. And that has to be done slowly so that it doesn't pump out. You see one eye comes out and then the other one will also come out. last one comes out. Okay, so that's that. And then you get a final angio and you see the gradients. Now you see all the leak has also gone and the valve is opened. So similarly, one more case, this was a 69 male, came with nocturnal pains, angina, admitted with accelerated hypertension, coronaries were normal, and was in LVF, and which was controlled on diuretic and nitroglycerine. But when we saw that, there was aortic stenosis and there was some regurgitation in addition. And again, so planned for the TAVI, this time this is a balloon expandable valve, which is, so you cross it, and that's the CT for analyzing the size of the annulus. And so the valve crossed with a safari wire placed in position. And now this is the balloon expandable valve. This is very much like a stent. So you inflate it with a balloon. You inflate it with a balloon. So that's there. Again, you do it under rapid pacing so that it doesn't jump out. So that is in place. And that's how it looks like after being in position. And again, there is no leak, and so these are the gradients pre and post. So that was about the tower. Now, a few cases of coronary complexities which can be handled, I'll just show. So this is a 66 male diabetic hypertensive, chest pain for 4 days with troponin positive. LVEF now, you see, is only 15%. ECG shows evidence of anterior MI. So that is QS, V1, 2, V3, V4, and that is the LV. You see it is very poorly contracting heart. So, well, someone would, we could do it on Impella also, but incidentally this patient could not afford it, so I had to do it without Impella. And then when you do the angiogram, you see the basal angios. So there is severe LAD disease, and you are seeing RCA filling through the contralateral, through collaterals. So RCA is 100% blocked. So that's the blocked RCA. And so angioanalysis is RCA is a CTO, LAD is critical mid, and that is the anterior MI by which the patient became symptomatic and came in. Circumflex was a small vessel, some 70% lesion. So, and globally hypokinetic because of poor remodeling. So plan was to do the LAD first, possibly as it is the culprit, wait for collaterals to develop, and then attempt the RCA CTO stage 2. Because with this, if I try to do RCA first, then patient will not withstand the procedure with that poor LV. So we did the LAD, so LAD has opened as you see here. You have to sometimes choose which vessel to do, which not. So one circumflex is moderate lesion, which we are not doing here. And then at the second stage, when we call the patient, you see good collateral filling of RCA from the LAD system. And then if you, but now you see the LV, I showed you the LV angiogram. Now this is the heart contracting after 2 months. So that heart improves. So even if you do it delayed, it can improve. That's what it shows. It's really improved after the LAD procedure. And then if with my interest specifically in CTO, I probably can do it. So bilateral injections and then CTO wires. And so the RCA was done stage 2. So under contralateral guidance, you can see, you can guide the wire into the distal vessel. So distal vessel has to be seen and shown if it is not seen. And then you further advance this wire and you get a final result. So another case, 49 male, non-QMI 4 months, continued angina ever since, cart outside, well, triple vessel disease and advised CABT. You know, several times you need to analyze that same angiogram again and maybe agree it is triple vessel disease, but then you need to see what type of lesions are there, whether each individually can be handled independently. So the basal angios, basically it is LAD diagonal disease as you see, and there is a long segment, but disease disease in the circumflex away from the left vein, so left vein is clear, and RC again has some long segment disease in the mid segment. So with that, we thought that maybe all of these lesions are doable independently, and we would probably avoid a CABG. The patient did not want that. So I did a LED diagonal. If you see two wires, so LED diagonal has been done first as a bifurcation. So once you get that result, then you do the Goel, which needs only a single stent, maybe a little longer one, and finally you can do the RCA. So you strategize the thing, and then you can handle things. Now this is an 80-year-old man, hypertensive with COPD, acute shortness of breath, metabolic acidosis, put on ventilator. So there is a high-risk patient, rising troponin, ECG shows right bundle branch block, but the patient shows severe LV dysfunction, which is acute, which was normal about a year back. Put on IABP and to control the situation, and then CARD done after 24 hours, which shows severe left main with TVD. Now it is 80 years on ventilator, he will not have surgery, he cannot have surgery. Culprit here is left main to LAD, so PCI done under hemodynamic support with Impella. Now you see that angiogram, so you have the IABP inflating here, and you will see this is left main. It has a filling defect, if you see, I wonder if you can see it there. It has a filling defect at the bifurcation point, and the LAD ostium is severely narrow. So in this, again, you think that that's the Impella that is being put in. So you can do the left main to LAD, which will salvage the patient. So that is the Impella inside. This again is a 14 French device. It is expensive, but in those situations where the LV is bad, you can use it. And then because of the heavy calcium, we used IVL. IVL is intravascular lithotripsy, which will break the calcium and allow the stent to go, otherwise the stent would not go. And then post IVL, the pictures are better. You see how nicely it has opened. And then you do a IVUS to see what size the vessel is and what size stent you need. So the vessel was nearly 4 mm, with left main almost 5 mm. So we put a 4 mm stent, post dilated to 4.5, and good result, and the patient recovered. Again, I think we'll shorten it down. Again, calcific disease, I think it goes on. I will, at the end, so that sometimes you need rota for the calcium. So this is a case where we did rota. And 2 overlapping stents. Sometimes CTO, if it is not possible antegrade, you can do it retrograde. Now this was a patient, 78-year male, hypertensive, recent chest pain with sweating on and off, no classical angina. ECG showed T inversion V4 to V6, and drop in fact was negative. So sometimes you get these patients, if your clinical suspicion of the pain is very strong that it is angina-like pain, every pain may not have a troponin positivity, because troponin will get positive only when there is damage. So it's not necessary that the damage has yet occurred, but he may still have coronary disease. And you see with that, the amount of coronary disease this patient had. So the RCA is totally blocked here. There is some disease in the LAD and circumflex system, and there are very strong collaterals to RCA. Yes, RCA is chronic, but something needs to be done here. So there were some bridging collaterals across the RCA. So I thought we can, maybe the RCA is culprit, we do it first, but it has jumped. Sorry, yeah. So then what options do we have? Either we ask for surgery, the severe triple vessel disease with the CTO also, or medical treatment only, well, that is one option. Or intervention, if yes, then which vessel and how. But this patient is not keen for surgery at all. So what the plan was, the RCA looks plus minus 100, maybe it is semi-acute, I don't know. So we tried the RCA and then do the LAD circumflex, which would be straightforward. But somehow this RCA could not be crossed, and it can happen. This RCA could not be crossed, tried enough. So then, well, you have to stop the procedure also. You have to know when to stop. This is very important. You can't keep going on and on. So we stopped it. But then but you can always give a second attempt, and sometimes you were successful in second attempt. So the family was okay and wanted a second attempt. So this time I took it up electively for retrograde to do the RC retrogradely. So we put the wire caravel in the LCX. So through the LCX across the AV groove collaterals, we're going to enter the RCA. So retrogradely, you see the wire is crossing and going up into the RCA. And finally, you could complete a retrograde procedure. And that's the final on RCA. So once you open this RCA, LAD circumflex can be done, and it was done. That was the basal one, and this is the final one on LAD. Now, sometimes surgical problems also occur where, again, you need intervention. Now, this is 1 year post-CABG, the Lima got blocked. It can happen. So then what you do? Intervening on Lima is more difficult. So you try to intervene in the native vessel. So the native LAD has a disease because patients undergo surgery or intervention have surgical disease in one artery, simple disease in another artery, but the combination calls for surgery or whatever. So you can put the wire in LAD and you open this LAD and you get a good LAD result. You see it here, and the patient would be fine. You can do ASD device closure as well. The ASD is seen here, sizing with a balloon, and then device in place. So, and that's final result. So what I wanted to conclude was, actually lots is possible with today's technology and operator expertise in the field of interventional cardiology. Must know your job well, know when not to intervene, this is very important, and must know when to stop. You can't go on and on. And you see only what you know. So the same angiogram seen by one eye could be different from seen by another eye. New upcoming area of interventional cardiology is structural heart disease, tower, mitral clip, as I told you, mitral valve repairs. And closures of holes in the heart is certainly in our scope, provided the operator is conversant with the same. Now, this is a statement which is a little provocative, but no offense against anyone. However, we still continue to refer all such cases directly to the surgeon. My only submission is the cases you feel it needs surgery, but do refer it to a cardiology person who can analyze it in that angle rather than straight going to the surgeon, because surgery, well, no one wants. So patient certainly deserves a better decision making. Thank you for your kind attention.
The lucid talk in such short time and covering almost all the important aspects of interventional cardiology. So basically, how to interpret the angiogram, make a diagnosis, plan the procedure, have the right hardware, and that is all that is required for a successful procedure to happen. And I would request anybody to open it to the people to ask any questions. Oh, so sorry, I forgot. Oh, so sorry. I forgot that.
Definitely ask during the breaks.
No, I forgot it.
It's okay. That's fine, no problem. Else we can.
I think Dr. Shahid just give a comment.
And I think the talk was very crisp and very precise, and it was like very understandable for everyone over here. All the procedures that you have shown, sir, it's a marvelous one. We can just imagine that how it can be done. So thank you so much, sir, for showing such good cases over here.
Thank you.
And just for the audience, we are doing these procedures in Allahabad also. A lucid talk in such short time and covering almost all the important aspects of interventional cardiology. So basically, how to interpret the angiogram, make a diagnosis, plan the procedure, have the right hardware, and that is all that is required for a successful procedure to happen. And I would request anybody open it to the people to ask any questions. Oh, so sorry, I forgot. Oh, so sorry. I
But
forgot
we
that.
can definitely ask during the breaks.
No, I forgot it.
It's okay, Tapan, that's fine, no problem. Else we can.
I think Dr. Shahid just give a comment.
And I think the talk was very crisp and very precise, and it was like very understandable for everyone over here. All the procedures that you have shown, sir, it's a marvelous one. Like, we can just imagine that how it can be done. So thank you so much, sir, for showing such good cases over here.
Thank you.
And just for the audience, we are doing these procedures in Allahabad also.
We also remember